Kia ora koutou, ko te raiorahiri te maunga, ko mankahia te awa, ko ngata toki te hapu, ko Naupui te iwi, ko te raiorahiri te marae, ko Tori Diamond sort of wingwa. Good everyone, my name is Tori, and I am presenting novel applications of the integrated data infrastructure, specifically around adding longitudinal capability to the Te Kupenga survey. This was a part of my master's project. This was funded by HRC, so I got a HRC scholarship for my master's, but also it was a part of the Te Haunui project as well, looking at longitudinal capability for specifically Māori health outcomes in the future. So this is kind of a small section of that as well. Also, just a thank you to my two supervisors, so Dr. Matt Edwards and Andrew Spall. Andrew Spall is from iNZight Analytics, as well as Nicole, who's also here today, where I do research, and I'm also beginning my PhD next week. Just to begin, I did use IDI microdata output, so I'm just listing these disclaimers here, specifically for the census, Te Kupenga, and IRD tax data. Cool. So as I mentioned, this was a part of my master's thesis. I did complete that in December last year, and what I will be presenting on is kind of maybe a third of the project itself. It was quite a lengthy project, way bigger than I thought it would be. So I am looking at whether administrative data can be used to transform the Te Kupenga survey on Māori wellbeing into a longitudinal study. So the aim was looking at the impacts of survey and administrative data determinants, the two health outcomes of Māori, for Māori, utilising a post-census survey or Te Kupenga. So to give a bit of background, Stats New Zealand's Te Kupenga survey is a survey of Māori wellbeing, as I've said. It's the only survey of culturally informed variables that's currently available. And the survey includes people who are 15 years and older and are of Māori descent and or ethnicity. So there were two iterations of the Te Kupenga survey, the first being in 2013 and then the second in 2018. The first survey in 2013 had around 5,400 participants, whereas the one in 2018 included more, which I think was around 8,000. And it is a nationally representative survey, so was quite valuable to actually utilise when you're linking to admin data. So going over the project approach itself, I used multiple data sources, so Stats New Zealand census, so 2013, 2018, as well as Te Kupenga, IRD, Department of Internal Affairs, Ministry of Health, and then core data for date of birth, date of death, and obviously spell records, which were used for censoring for people from the sample. And the survey sample that I used was Te Kupenga 2013 as the base cohort. And the outcomes were ambulatory sensitive hospitalisations, or ASH, and COVID vaccinations. So I chose to use Te Kupenga as the base cohort because in order to get more of a longitudinal view, and it was the first iteration of the survey itself. So this is just, if you can see that, it's kind of just an overview of the two outcomes that I used. And firstly, I'll go into results, firstly data sources actually, and then results for ambulatory sensitive hospitalisations. This first image is a list of the explanatory variables. So these were pulled from Census 2013 IRD, and they were mainly at an individual level. So for Census 2013, I used individual data set and then linked that to Te Kupenga 2013. And took a range of variables from that list as well. And then I supplemented it with IRD data just to check against income, self-reported income, which I'll go into later on. So like I said, the outcome of interest I'm talking about first is the ASH binary record. So the binary record is whether or not someone had an ASH event or kind of preventable hospitalisation between the period of 2014 to 2017. So I used that outcome period because it directly followed the base cohort, which was from 2013. And to add to that, these were from publicly funded hospitalisation discharges. I also manually coded that data set to reflect the ICD-10 clinical codes that Ministry of Health uses to actually classify ambulatory sensitive hospitalisations. So that was a bit of a lengthy process as well, but that was done right at the beginning, so I don't really think about it now. But this image here does outline the fact that I did actually look at other outcomes for ASH. So I did also look at ASH length of stay and ASH unique events. However, I only looked at those on the national scale. So like I said, what I'm showing you today is kind of like a third of my master's project. And these other two outcomes that are listed here, I used at the national scale. So I'll just be focusing on the binary record. So going into the results for the ASH events between 2014 and 2017, looking at logistic regression, so because we've got that binary indicator variable, so 0, 1, so 0 being no ASH event versus 1 ASH event. Like I said, I did mainly use individual explanatory variables, and I did run quite a few regression models. However, these were found to have the largest effects. So sex, females have greater odds in comparison to the baseline of males of having an ASH event if you're aged 45 years and above. Specifically, if you are aged 75 years and above, in comparison to 15 to 24 years, you have a higher odds of having an ASH event. Individual income, those earning between 1 to 50,000 annually have greater odds of an ASH event. Also, if you have a disability, same thing in comparison to no disability. And the other thing to add here is that medical discrimination that variable comes from Te Kupenga 2013, which was of interest as well, to actually see whether Te Kupenga has an impact on health outcomes, or what they measured within that survey has an impact. And what we found was that medical discrimination does increase your odds of having an ASH event. Going back to the project approach, I'll now go into the second outcome, which was COVID vaccinations. So once I finished that portion of looking at ambulatory sensitive hospitalizations, I wanted to look at something that was a little bit more timely and incorporated elements from Te Kupenga 2018 as well, which I didn't in that first outcome. So this was a 3-category outcome variable, which was no vaccination, partial vaccination, and full vaccination. Going into the data sources here, sorry about it being a little bit small. I used Census 2013, Census 2018, core data, and IRD data again. For the 2013 census, I used the Te Kupenga cohort. That's the idea here, using that base cohort and following them throughout time. So then I linked them to Te Kupenga 2018 to incorporate elements from that survey itself, then went to individual, dwelling, and household. Personal detail table was used here because it was important to take into account someone's eligibility to be vaccinated or not, because that did change through time as well. Depended on age, depended on your last vaccination, how many vaccinations were available at the time. So Just also noting, I did take vaccinations from up until January 2023. So that was about a year and a half ago. Yes, so the outcome was used from the COVID immunisation register, which was sourced from the Ministry of Health. And like I said, that 3-tiered category variable from 2020 onwards. And the other thing to note here was that I incorporated censoring variables just to make sure that everyone in the numerator was included in the denominator and vice versa. So date of if someone had left the country prior to the outcome period before 2020, and if they had passed away before 2020. It was important to make sure that they weren't in the sample. So because of that 3-tiered category outcome variable, I used an ordered logistic regression. So interpreting these results, you can interpret them as combined partially and fully vaccinated versus non-vaccinated. And these were found to be the greatest effects out of many regression models. So sex, females had greater odds of being partially and fully vaccinated versus non. Below 100,000 earned annually in 2018 displayed lower odds of being partially and fully vaccinated. And then from Te Kupenga in 2018, which was quite interesting, trust in fair healthcare. If you had increasing trust in fair healthcare, the odds of you being partially and fully vaccinated were higher, as well as how your whānau were doing. So how you personally related to how your whānau were doing, or what your perspective of that was. When that increased, your odds of being partially and fully vaccinated also increased. However, one thing to note as a disclaimer is that because of this small sample size and the potential loss to follow-up, there was a relative sampling error of around 40%, so it is important to take that into account when you are looking at these results here, specifically those last two from Te Kupenga 2018. So the other thing I wanted to go into was my reasoning behind choosing IRD admin data for income earned annually in comparison to using self-reported census income. So I'm looking at survey-weighted responses for 2013 cohort, and these are using the 2 data sets, so they are matched at the same time period for when income is measured. So these are survey-weighted responses for that Te Kupenga cohort. So what I've got here is on the diagonal, so the entries in black, they are in agreement. So the 2 data sets align, or responses align. The other thing to mention is that census individual income, there is an option to say that you've had a loss or no income, whereas IRD doesn't necessarily measure that because it's only measuring what's actually been entered into their tax data entries. So the important thing to note here is that when you've got a small sample, it's important to be using the right source of income, in this example at least, because when you've got that off diagonals, or the entries either side of the diagonal, there is quite a high discrepancy between what should be recorded versus what is recorded in self-reported income. So I just wanted to use that as an example. So what's the point of all this? The point is that Te Kupenga is the only survey within the microdata level of output that has culturally informed variables that actually have really significant and meaningful impacts to Māori, and also the potential to use those to look at health outcomes and even other outcomes for wellbeing. So like I said earlier, medical discrimination, trust in fair healthcare, and how whānau are doing were found to potentially impact health outcomes, at least for this project here. Simultaneously, there were issues with using survey data as a cohort source. especially when you're looking at self-reporting versus admin data, which outline potential biases, whether these biases are just people not necessarily knowing their real income, because not everyone does know that off the top of their head, completely get that, or whether there is a bias in, when you are speaking to someone in an interview, how do you want to present your income to someone? So I think it's important to utilize admin data that's validated and that can be, I guess, more reliable for the long term as well. Additionally, loss to follow-up was something that I had to consider using a cohort from 2013, and it was important to quantify the size of the loss to follow-up, as reweighting may need to be required when using longitudinal approaches in the future.
Did you find anything interesting in comparing the partially vaccinated to fully vaccinated in terms of, were there any kind of factors that differentiated those groups?
Off the top of my head, the results were very similar to what was mentioned in the previous slide. Go back, show you there. They were very similar off the top of my head. And also when you're using ordered logistic regression, you can actually flip that definition as well, because it is a grouping when you're interpreting those results. So yeah, off the top of my head, it was very similar, but I can also look it up for you.
Just wondering, in the the results there, you presented the variables that had a significant impact.
Yeah.
Were there any of those variables in the Te Kupenga survey that you thought would have an influence and didn't?
There were. I thought potentially that any medical discrimination might have had an impact for COVID vaccinations. I know it had an impact for ASH outcomes, like I displayed earlier, but I did wonder if that would have an effect. And the other thing is that for COVID vaccinations, I did take an approach where I wanted to look at individual, household, and geographic factors as well. So I did think that maybe household factors would also have an influence, but they didn't, from what I can see. Yeah, and same with geographic. Yeah.
What other areas are you looking at taking this analysis to? Is there like a next step?
The next step is I've had a lot of encouragement to publish this work. It is, I completely understand it is, valuable. At least in my experience, I don't see too many cases where people utilize Te Kupenga in this way. And finding these results has been really important, and they're quite, I guess, stark. But I guess it's from here whether we could look at it in increasing that longitudinal lens as well. Yeah.
Did you, this probably would be the next part of the work, what about when you've got people who didn't get the vaccinations, but did get COVID, and the ordinary people who also had vaccinations and still got COVID as well? Is there something that can be done in that space, or see if there's any disparity or empirical?
So Nicole Satherley, who is presenting next, who's also a part of iNZight Analytics, has done a fair bit of work in that area, but not necessarily on no vaccination. I could be wrong. But
just a general report on no vaccination, partial, full.
Yeah,
similar to this. So that's
similar. Yeah. So I mean, there's a possibility to look into that as well. Yeah, I think that would be interesting.